Hi, I'm Jerry Hesch, physical therapist at Hesch Institute in Aurora, Colorado. And I have Dr. Benner here. He's an emergency room physician who has had a couple of surgeries. Can you give us a history on your ankle, please?
Yeah, I broke that when I was like 13 or 14 through the growth plate of the tibia, and then had that reduced and casted, and then the following year I had a fibular fusion on that side because the fibula kept growing and the tibia didn't. And then I've had multiple ankle sprains after that surgery, on the left only.
And isn't it all symptomatic?
No.
Yeah, very good. So you live well with it. He also presents with some right knee pain, and he's had hip scope on both sides for FAI, femoroacetabular impingement, and labral tear, and a little chondral defect. And then he also had a fusion at L5S1, and so he came to see me mostly for his sacroiliac, but also low back pain, right knee pain, and bilateral hip discomfort. So I wanted to show the difference in his subtalar joints, and I know that the camera probably can't capture what I see, but we'll do our best. Okay, so this ankle and foot has pretty free mobility on the midfoot, and when I capture the heel, the calcaneus, I can abduct it. I can move that outward, and I can also evert this heel. On his left side, the midfoot is very restricted when I try and pronate it. Very, very rigid. And when I capture the heel, I can only abduct to neutral. There's no more movement of that foot moving outward. And when I try and push the heel into eversion, I can get to neutral, but I can't really evert it. So he's functioning in more supination. And I noticed that when you were walking, it was very obvious that this subtalar joint functions in greater supination than the other side. I did test the anterior talofibular ligament doing a drawer test, and I get a little bit of movement. I'm sure it's too subtle for the camera, but I don't think that ligament is torn. I think it's a fact that we have a movement dysfunction that's contributing to a little tiny bit of apparent laxity. And the same is true when I invert him. I can invert him what looks to me to be 35 degrees, but then when I overpressure it, I do not get excessive movement. Whereas on this side, the inversion is to about 20 degrees, maybe 25. Okay? Now if you would lift this foot up and out and show me how strong you are, and I'm not able to break that. Very strong. So evert on this side, show me how strong you are, don't let me break it, and it's so easy for me to break it. Okay? And that's an inhibition from the joint dysfunction to the best of my understanding, because after we correct that movement, we'll retest it, and typically that kind of inhibition releases when you restore normative mobility. Okay? Now we'll focus on his knees a little bit. I can hyperextend his left knee somewhat, and there's greater range on this side. Can you tell the difference?
Yeah.
I can go further on the right.
Yeah, and when I walk too, it feels like this knee flops all over the place, and I gotta kind of compensate. I don't know how to explain that feeling.
Interesting.
It's always when I put weight on the right side.
Yes.
Where it kind of feels like, it kind of just moves to the side almost.
Oh,
or, I don't
interesting. Yeah. We noted that he has less medial and lateral patellar mobility. I can get a little bit, okay? On this side you can see there's a lot more medial and lateral mobility. I can squeeze this patella and it lifts up. And when I squeeze this one, it doesn't lift up. I can't quite get underneath it like I can on this side. And there is less inferior glide of the patella. This one has a lot freer inferior glide. Okay? Now when I test posterior spring, I can take up the slack on this femur I can spring it and it bounces right back. On this side, I can't take up the slack. There's no movement happening at all. Whereas on this one, when I push initially, there is some movement until things tighten up. And then I add an additional spring, and I get a spring and a recoil. On this side, I can't even take up the slack. And I'm doubling the force. I'm tripling it or more, and there's no give there. And so it appears that he has a glide dysfunction in which this femur is stuck in posterior glide relative to the tibia. And so we will treat that shortly. And the other thing that we find with his pelvis is that he does have an asymmetry of his pelvis, which he's been aware of. And on the left side, I can take up the slack and spring it. There's spring and recoil. And on the right side, the slack takes up so quickly. There was just a tiny little bit of movement there. And now it feels very, very rigid. And I'm using more force than I used on the left side, and there's no movement. Okay? And this is this pattern, I believe, is a twist of the whole pelvis. Some people say it's the sacroiliac joint, but even in symptomatic patients, you look at the research and the sacroiliac joint only moves a couple millimeters and it only rotates a couple of millimeters. So the amount of difference that we see here is much greater than that. So you have to look for a reasonable explanation, and that would be that it's the whole pelvis has oriented asymmetrically, the whole pelvis moving relative to the hips and with the hips and with the trunk as well. So I'm not saying that anterior ilium equals sacroiliac joint dysfunction, but it does equal reduced mobility traversing through that joint. So it might be an external restrictor of normal forces going through that joint. I hope that makes sense. But I think we'll summarize things. So we have a blocked subtalar joint on the left, reducing his abduction of the heel and eversion of the heel, inhibiting his fibularis muscle group, or the old term is perineal muscle groups. And we have a posterior glide fixation of the right distal femur. And we have what we call an anterior ilium on the right. And I did screen the rest of the body. And typically when you have an anterior ilium, or when you have this pattern in the ankle, typically there's a counter rotation up high in the cervical spine. But these three things interact such that apparently your body doesn't require that distal compensation because your upper cervical mobility was very, very good. So it shows that I'm paying attention. I'm not seeing a pattern that I would predict.
Yeah.
So that makes me happy. So we will treat him very gently, and I think I'll go ahead and show the treatment right now, what I'm going to do with you. And basically I'm going to just distract the subtalar joint. So I'm going to pull on your heel for about 30 seconds, stabilize tibia, and then I'm going to do 30 reps of, I like the term external rotation, but the formal term is abduction of the calcaneus of the heel. And so I'm going to do that, and that should normalize mobility in this subtalar joint. Then I'm going to pull this femur anteriorly. I just thread my forearm underneath it, okay, and I block the tibia and I lift up. That's an exaggeration, but I'm going to lift up against a blocked tibia, and I'm going to do that for 5 minutes, okay? And then, to correct the anterior ilium, I'm going to have you hug your knee outside your shoulder, so grab it with both hands and stretch it outside of the shoulder. Good, so it's out there at about a 25 or 30 degree angle, and he'll do that for 2 minutes. You'll do that also as a home program. And the knee correction should be a one-time correction. I will teach you an exercise to keep the mobility in that subtalar joint. And basically, once a week, you'll grab the heel. You'll kneel on the sofa, and you'll grab that heel and push it down away from my leg inferiorly, and then you will twist it grab that heel and you'll twist it 30 times. Okay? And then we'll have you do one more exercise in which you stand and point your right foot all the way out to the right. You're going to twist your body to the right, and you're going to do 100 little tiny oscillations so that you teach that, you reproduce that rear foot and mid-foot pronation. And we'll have you do 100 a day for a week, and then 100 a week, once a week thereafter for a couple of weeks.
Okay.
So we can stop filming now, and I'll go to treatment. It'll take me about 10 minutes. Thanks.